Try to cover both congestive heart failure and cor pulmonale in this video because I think these topics are really small topics. So congestive heart failure is just congestive heart failure is equals to left heart failure and right heart failure. Simply, the most common cause of right heart failure is the left heart failure. Now this is a this is a big statement, okay, because usually your right heart is not meant for big pressure handling, right? So usually that's why uh, you guys have, we guys, myself including, we have problems in the left heart. Why? Because left heart deals with a lot of pressure, okay? Left heart is thick, left heart is bigger in size, and this is the reason usually we have left heart, problems, because left heart is more hard working than right heart. Usually right heart is okay. So simply adding together, right, left and right, we call it congestive heart failure. Now in congestive heart failure, we'll see both left and right heart failure findings. That the patient have dyspnea, they have JVD, they have peripheral edema, right? PCWP is elevated in these patients since left heart is the pathology, right? So if we see some sort of, peripheral edema, plus we see increased what is this, PCWP, right? So we see peripheral edema, PE, plus PCWP, that's the wedge pressure, right? Pulmonary wedge pressure. We can call it as congestive heart failure, I think. We're not gonna call it, it's like the findings we see, so that's the idea. So what's the idea here is that we have body, right? In the body, the body pushes the fluid inside the right heart pushes inside the lungs pushes the fluid. No, they don't push. Usually is the fluid, the blood moves, right, from lungs to left heart, and then left heart pushes the body again inside the body, right? Left heart pushes the fluid inside the body. Now if the left heart fails, the pulmonary vein hypertension, this is the pulmonary vein, right here is the pulmonary vein. The pulmonary vein hypertension happens. Now once this happens, now the right heart has to overcome this increased pressure in the lungs, right? This pressure that was created due to failure of left heart. Now the right heart is now getting bullied because the left heart is not working hard, right? So the right heart is thin wall. It's not meant for really high pressure. It's built for volume, not pressure. Now due to the increased afterload is just that this is the afterload, right? Because how do I say afterload in short terms? In nutshell. Now afterload in nutshell, it's just simply, I'm trying to put this in words, it's just how the resistance, right, the resistance that heart must face or must pump against to eject the blood. Now think of it as the pressure wall your ventricle has to push open to get the blood out, right? I want to explain this very simply. For example, let's take left ventricle. Now afterload here is the aortic pressure, right, or the systemic vascular resistance that was created by your arterioles, right? So this is usually afterload, right? So we have increased afterload because this left heart is denying blood from the lungs, and now lungs have hypertension, a lot of blood accumulation here. Now this increases the afterload for the right heart. I hope you get it. Now due to increased afterload, we have increased resistance, and then we have right heart problem. Okay, so that is congestive right heart failure, right? Congestive heart failure, heart failure, not right heart failure. Okay, let's go into cor pulmonale. Now cor pulmonale is a cool word. Now wherever you see pulmonale, it means something wrong with the lungs, right? So let's read what the text is there. Cor pulmonale is defined as the right heart failure due to pulmonary causes. In other words, left heart is completely normal in cor pulmonale, but the PCWP is normal. Now if the PCWP is normal, that suggests us that the left atrium is normal as well, right? Now if the left atrium is normal, that suggests that the left ventricle is normal as well. Now in this disease, the left heart is completely normal as the right heart is failing to pump the blood inside the lungs. And once the right heart is failing, the blood will push back inside the right heart, and then it will increase the pressure, right, in the right heart, right? Once the pressure in the right heart increases, we will have this JVD, that is the distension, jugular vein distension. So cor pulmonale will have a JVD, right heart failure, sign. It will have peripheral edema because the blood will pool back inside the body, right? This is the scheme, right? That's how the blood moves from the body to the right heart. Now imagine the right heart is failing right here. The blood will pool back inside the body, and this will give us peripheral edema, right? So that is this very normal finding. Now, cor pulmonale, in the setting of obvious overt lung diseases such as 100 pack year smoking, cystic fibrosis disease, right? Cystic fibrosis disease, we have problems in these chlorine channels, chlorine pumps, right? So with the cystic fibrosis, pulmonary fibrosis, we have pulmonary fibrosis means the lungs have fibrosed due to the injuries that was happening in your lungs again and again due to some sort of active carbon particle, or maybe some proton, or maybe smoking carbon atom, something really messy happened in your lungs, and now your lung have had trauma, and they have healed, and due to the healing again and again, the fibrosis of the lungs have happened, and the parenchyma of the lung has actually changed. So we have pulmonary fibrosis. Now they can present with lung findings such as wheezes. Now what is wheezes? Now let me tell you what is wheezes. First of all, I've written that both cystic fibrosis and pulmonary fibrosis, they produce hypoxia. Now this leads to vasoconstriction, remodeling, and loss of capillaries. Now once this all three happens, we have right ventricle overloading because lung is now denying the blood, right? So that's why we have increased JVD due to the lungs being a bad lung, right? So this is happening right here. So they can present with wheezes, right? Now what is wheezes? Wheezes is just a sound, right? And it happens when, I've written already. So wheezing is a musical high-pitched sound, and it happens on expiration. That's very important to understand, and it's due to bronchoconstriction. Just like a whistling, this is wheezing. Whistle. Okay, wheezing, not weasel, wheezing, right? Weasel. Okay, so it just doesn't seem like they're focusing on the left heart, right? The NBME, and as the cause of the right heart failure here, it seems like the 100-year packing causing COPD, why right heart is failure. Okay, that's very simple things. Now, it can occur due to bronchopulmonary dysplasia. Now, what is bronchopulmonary dysplasia? It's just that the remodeling is happening, right, due to hypoxia and vasoconstriction. Now, dysplasia is just when a normal structure is displaced by an abnormal one. That is dysplasia in simpler words. So, arrested alveolar, they are larger and fewer, and development due to prolonged O2 therapy, immature lungs, BPD in precursor is chronic. We are talking here about little kids, by the way, right? So in little kids, we have this bronchopulmonary dysplasia, right? And why it happens? Because these little kids are lacking something called, maybe they are lacking in surfactant, maybe something's wrong with their lungs. And when something's wrong with their lungs, their alveolars are arrested now. Now, once the alveolars are arrested, these alveolars, they become larger and fewer because they are now, conjoining with each other. Now, the development due to prolonged O2 therapy, now these kids, these small little neonates are put on oxygen, right? Oxygen therapy. And once this oxygen is, once their lungs are getting exposed to oxygen again and again and again, these immature lungs will develop something called as BPD. It's what is BPD? BPD, bronchopulmonary dysplasia. Now they will have bronchopulmonary dysplasia as a precursor to the chronic lung disease they have. So actually, O2 therapy is the main cause, but we cannot do anything because they have arrested alveolars, right? We need to give them high O2 therapy. So O2 therapy is the reason for dysplasia in the lungs in these neonates. So bronchopulmonary dysplasia in premature neonates, right? Or obstructive sleep apnea, right? A lot of people, they when they sleep, they have some sort of obstruction and they wake up, a lot of times in the night. Since since the lung disease backs up in the right heart, the patient can have boot-shaped heart colloquially, which refers to right ventricle hypertrophy without the left ventricle hypertrophy. So only the right heart is getting bigger in size because right heart is handling now bigger volume, because bigger volume leads to more work, and then more work leads to hypertrophy, and then we call it as a boot shaped. And basically what happening is that here is that it's actually it's pushing the heart in the midline. Okay, so if the patient has COPD, the massively hyperinflated lung, right? Why hyperinflated? Because air is getting trapped inside the lungs. Okay, so usually what happens here is that due to anatomical structure, air is not supposed to get trapped inside the lungs, because we have these what is it called, these ligaments, not ligaments actually, these what are they called, I just forgot the name, but anatomically your alveolars have these structures. I don't remember the name, but your alveolars are not supposed to they collapse, right? They're not supposed to collapse, but they do collapse. And usually before collapsing, the air rushes out from that area so that no air is trapped inside the collapsed area, right? But due to some abnormalities or due to some disease, right, due to some changes, this air is starting to get now trapped inside this collapsed area. So usually what happens is that the collapsed area increases in these diseases. For example, I take this area as 10 by maybe 5, right? So this area is around 50 meters square. So normally what will happen is that only this area is getting collapsed, right? And this area is anatomically healthy, it's not getting collapsed. Air can rush out, rush in, everything is okay. So usually air goes in here, the O2 CO2 change here happens, and then air comes out, and then this collapses. But here what happens is that in the disease, now I'm gonna make the area again. This is the area again, 10, 5, and this is all 50 centimeter square. Usually this area of collapse increases. Once this increases, the air's gonna start to getting trapped here. And a lot of people, they call it, I think it's like a drum, it's like a drum of lungs. You basically, we are inhaling the air and exhaling the air on a already filled lung. This lung is already filled out of air. So we have hyperinflated lungs that will push the heart to the midline, right? So this is the lungs, right? And the heart is here, and this heart will go towards the midline of your body, right? So we have this midline heart, right, causing long, narrow cardiac silhouette with a point of maximum impulse in subxiphoid space, or we can call it apex beat. Now let me open it up a little bit. In contrast, if we have some sort of left-sided cardiomegaly, the broad globular lateral displacement happen. Okay, so it's really simple. I mean, if you really read it again, heart is getting pushed on the midline, right? And then this this maximum impulse can be heard at apex beat. That's what the text is saying. Now you must know that pulmonary hypertension is the reason for the right heart decompensates, right? Now in both cor pulmonale and congestive heart failure, the right heart experience increased afterload because the pulmonary hypertension is happening, right? Now there's something called endothelin 1. Now this is a vasoconstrictor, and this is made by pulmonary vascular endothelial, and it promotes smooth muscle proliferation. And that's why your endothelin, your this vasoconstriction in this hypertension can happen in lungs, right? So endothelin is responsible for the hypertension because of the vasoconstriction, right? So we have more endothelin due to vascular endothelium, right? So this endothelin 1 is a vasoconstrictor and a key mediator in the pulmonary hypertension. Your assembly wants you to know that this is increased in both cor pulmonale and left heart failure, right? because left heart failure leads to increased pressure in the lungs, and increased pressure leads to hypertension, and then hypertension leads to endothelin 1. Cool. Why bosentan? Well, bosentan is an endothelin 1 receptor antagonist. Now, why? Because it's a treatment for pulmonary arterial hypertension, okay? Bosentan. That's really simple. Other thing we can give is nitric oxide synthase. In contrast, USMLE wants you to know that it is decreased in pulmonary hypertension, which makes sense because since nitric oxides dilates, right? It's very simple. Allowed P2. So we have P1, right? So P2 is just, it's simple. P2 is just pulmonic component of S2, right? And pulmonic valve, pulmonic valve, or whatever you want to call them, pulmonic valve, they close and they make this sound. And due to increased pulmonary atrial, hypertension, due to increased pulmonary artery pressure, right? It's increased really. This pressure is really high due to hypertension in the lungs. The pulmonic valve, it shuts harder, and then we have accentuated P2. So that's why we are able to hear P2. And a tricuspid regurg as well. Now, a tricuspid regurg is happening. Okay, so regurg is just that, for example, this is, okay, let me make one more. So this is a gate, right? Just imagine this is a gate, right? And this, okay, wait, let me make again. This is a gate, right? And once I go out, I go out. If I'm able to return back, it's due to a shitty door. That's why I'm able to come back. So that is regurg in simpler terms, right? So we see tricuspid regurg because of the increased pressure in the right heart, right? And then we have high yield. These are high yield finding of Cor Pulmonale, and I discuss these more details in the table below. So that is cool. So absolutely follow Mehlman, and he's amazing. These PDFs are really amazing. I love reading them because they are really high yield. I don't like to study a lot because I don't like to just study garbage information. I like to study really something which is high yield. You can know a lot of things, but you should know what is being tested. So I really believe in that. So that's why I love this this platform.